talking now on the use of fixators in mal or ununited Lisfranc injuries. Just showing a couple of cases here again. So this 33-year-old male presents with a painful limp and a deformity in the foot. So he had a road traffic accident and suffered homolateral Lisfranc fracture dislocation, along with the fracture of the navicular and cuboid, which was then fixed with the navicular was fixed with screws, and the Lisfranc was held with K wires and just a U-mix kind of fixator on the lateral side. And this is how he presented 6 months later with painful foot. The orange arrow is pointing to the Lisfranc joint. Here again, on there's increased space. The navicular is probably not united or malunited. There is some void at the cuboid as well, which is pointed out by the green arrow. So what should we do? Just fuse it, or do a sort of staged reduction and then hold it with the fixator? So the idea was we'll put on the fixator, do an osteotomy and distract it, reposition, and with that then we convert the fixator into internal fixation and a cast. So this is the intra picture. We have applied metatarsal distractor fixators, which is just like LRS fixators, which can take in 6 mm shank screws. So these are 3.5 to 4.5 tapering shank screws going from both medial and lateral. Couple of pins in the calcaneum. On the medial side, one in the medial cuneiform and the first metatarsal, and on the lateral side into the cuboid, 5th metatarsal, and calcaneum, and an osteotomy of the navicular, just a percutaneous osteotomy. This is how the fixators look from both the sides, and started distraction on both sides equally, 0.5 mm to begin with, and gradually, as he could tolerate it, we increased it to 1 mm per day. So the deformity is just as is, and this is how the distraction has progressed over 1 month. The orange arrow is pointing to good enough space between the first the medial cuneiform and the navicular. And now the medial arch is restored just with the distraction. Nothing yet for the valgus. So now we have planned to take out the fixator. For the cuboid defect, we have used a tricortical graft and then fix everything together with screws. So that's the tricortical graft there, being held with the cortical screw to the navicular, lateral portion of the navicular. Then the medial cuneiform and the first metatarsal is held again with the rest of the metatarsals, and restoring the arch and correcting the valgus in the forefoot. That's at 4 months. Everything has healed well. The cast was there for a couple of months, and then he had a removable splint, and he was protected for a little longer time, but all the while he was allowed to do movements. Now that navicular has fused well with these cuneiforms, and the lateral arch is also restored. Reasonable functions, pain-free foot, And this case 2 was a 13-year-old pediatrician. He had a crush injury of the foot 1.5 years back, and then that soft tissue defect was skin grafted. Because of all that, no internal fixation was done, just managed. The tarsometatarsal dislocation was managed conservatively. And then he presented with pain and deformity in the foot. So on presentation, he had a similar kind of issues. The cuboid was there, but it was dislocated plantarwards. The forefoot was shortened. There was cavus, pronation, and valgus. The lateral arch was collapsed. That's the dislocated cuboid there. Notice the valgus in the forefoot. And that's the cuboid there, which is dislocated, pointed again with the orange arrow. And that's the comparison of both the feet. So we applied this hexapod fixator because this was just a midfoot, largely a midfoot correction. So just full rings. This was the days of original Litos hexapod, which would need a full ring on both the proximal and distal. So this contraption around the calcaneum, the proximal ring, just being extended to the tibia to hold the talus in place. A midfoot osteotomy was done, and the plan was to first distract it and then correct the varus angulation and the valgus angulation with varusization, and also get some medial translation of the foot. So at 2 weeks of distraction, now the angulation seems corrected. But on the lateral X-ray, what we see is now the talus is sort of getting pulled anteriorly. The orange arrow is pointing to that. So we took him in again just to make sure that the osteotomy is complete and it's not putting any undue pressure, and also added a shank screw to hold the talus with the calcaneum. And the distraction continued, and after 1 month of distraction, that's the orange arrow pointing to the osteotomy. Distracted, pronation has been corrected, and now the fixator is converted to internal fixation with screws, followed by cast application. The fifth MTV was getting sublux, so that has been fixed with a wire as well. And then he went on to have uneventful healing. The arch has been completely restored. So that was the cavus. No, valgus and rotations as well, corrected as well. So Lisfranc injuries are basically a very complex mechanism of injury. So one needs to understand what fixation you want to do and restore the anatomy. That is the best first chance to salvage everything. Oftentimes it's mistreated, and then these patients are banned for painful foot and deformed foot, and then ultimately land up with fusion in the midfoot joints as well. So what we want to highlight is osteotomy and fixator assisted correction